Is it recording?
Yeah.
So hello everyone, welcome to this MSK Playbook talk. Thank you so much for coming. I'm just going to give a couple of minutes for people to start coming in. I'm going to have a quick sip of my tea. I hope everyone's well. If you can, if you want to, please put hello in the chat. So what's going to happen today? We are going to go through what the MSK playbook actually is. And we're going to actually give you some knowledge today, really make use of your time to teach you a little bit about the patella and some of the pathology that can come up. I'm going to go through some of the imaging stuff. Dr. Irfan's going to go through some of the more kind of management-y stuff that he gets up to. Yeah, hi, thank you. Thank you so much for coming. Really appreciate the messages. So to introduce myself, first of all, I am Dr. Lasker. I'm a consultant radiologist, and I think we've got a few people, so I'm going to get started. Hopefully everyone can see my screen. Obviously, tell me if you can't. We're going to go full screen now. Okay, so this is it. We are here. This is the MSK Playbook webinar, right? The main focus today is going to teach you about the patella because some of you, yeah, there will be a video available later. We'll send a link out later as well. Some of you may be interacting with patients and they may come in with a few knee problems, and one of the knee problems may be to do with the patella. And so today we're going to go through some of the imaging findings, and we're going to go through some of the management, and we're going to give you the up-to-date information that's going to come from Dr. Irfan Ahmed. So Dr. Irfan Ahmed, who is he? If you don't know, I don't know where you've been. So you get on Twitter, get on social media, have a look. He is one of the authors and pretty much the chief author and person who's come up with the MSK playbook. I think he's seen a problem where there's not enough understanding with regards to imaging and management, and so he's trying to kind of bring those two things together. Do check his blogs out. It's on the British Society Sports Medicine Journal. You'll be able to find loads of links. If you do want to read some of the articles, which are completely free and have been shared thousands of times, then go to the MSK Playbook website and you'll be able to click on free stuff and you'll be able to find the actual links to all the articles. You can download these things as well. We've made really nice graphics together and example images of various pathology that exists when you may have a patient that's there. We'll give you a sneak peek into one that's coming up soon. And we will also, yeah, I mean, there's always the opportunity to work together on other playbooks as well as time goes on. But this has been really, really popular. People have loved it. People have loved it and shown it a lot of love. So if you do see it, also give it a share, give it a like, and all the rest of it. So Dr. Irfan Ahmed is a sports medic, and he's going to go through medical workup, talk about bloods, red flags as well. I think that's a big, big issue for a lot of us medical professionals or anyone that works with people. You worry about red flags. And for those that don't know, I'm not talking about flags of a country. I'm talking about the problem where there's something that's happened and you're really worried that this could be something else, right? And when I say something else, something sinister, something to really worry about. And we're going to go through some of that as well today, so that hopefully, if you learn nothing else and you're not going to sign up, which is fine, by the way, completely fine, you will have learned a lot of stuff from this one talk that you'll be able to take forward with your practice. So me, yeah, I've already talked about myself. I am a consultant radiologist. My specialist interest is MSK radiology. I've been doing lots of teaching. I've been on Radiopedia, Collective Minds. I do radiology seminars. I've been on Everlight. I really, really like to teach. I really do. And I think there's a lot of merit in teaching. And I'm very lucky that I do a particular subspecialty where I think it can make a big difference to a lot of people, right? I personally believe that if everyone could get good at imaging, at least to a decent level, then I think the world would be a better place. How long's the webinar? Webinar shouldn't be too much longer. I think we're probably going to be, I'm aiming for about half an hour, 40 minutes. If it goes over, sorry, I'm going to try my best. There's a lot of information to go through. It will be recorded, so if you can't stick around, that's fine. Just catch up with later. What I'd say is at the end of the webinar, we are going to give a special offer because obviously I value time and I want you guys to get the most out of it. And if you guys want to go further, then I want to reward that feeling. So yeah, I'm going to go through the radiology stuff. So the webinar, the course, what are we trying to do? What's the whole point, right? So a lot of you guys most likely will be working with patients and will be working with musculoskeletal problems, right? We're talking about bones, we're talking about joints, we're talking about muscles, all of that stuff. And at some point, someone's going to get a scan and someone's going to come and say, oh, you know what? I've had a scan. Do you mind having a look? Now, radiologists like myself are pretty elusive. You're not going to be able to find me, have a chat to me, especially if you've got a person who's going to come in through the door and maybe stick in that CD and say, do you mind just having a look? And maybe you know something about it, right? So I'm going to show you, or we're going to show you, how to look at the MRI scans or any sort of imaging, kind of go back to basics, think about the anatomy, what it's looking like, and then also be able to present it to your patient. Because also, what you'll find is when you've got a patient with you, you want to build up a rapport. You want these guys to come to you, think you're awesome, and go away thinking, you know what, that person's really good. And one of the ways that we feel is the way to do it is to demonstrate a lot of knowledge in various aspects. And imaging goes a long, long way, right? So if you got someone who, let's say, has got supraspinatus tendon tear, and they say, "Oh, can you read the report?" And then say, "Oh, but do you mind showing me?" And you say, "You know what? Yeah, I'm going to show you." And you put it in, have a look, and are able to demonstrate the pathology, then that just puts you on another level, way above a lot of levels from other people that are in the same game. So I get it. Some of you guys may have read some of my reports or other reports, and they've come out with all these phrases, right? T1, T2, stir, contrast, incidental findings. Oh, radiologists love incidental findings. It's like the bread and butter of radiology. And then also you're thinking to yourself, okay, what is age appropriate versus not age appropriate? And when we say that line, we drop it, don't we, sometimes, radiologists? Clinical correlation advised. And they're thinking, all right, so basically you've thrown it back at me. Now what do I do? So I am going to try and break that barrier today. We're going to try and break those barriers so that when these things come up, you've got a bit more of an idea about what you're looking at in the first place. So here's a rare picture of me outside of my office doing some teaching. And this is what happens to a lot of people. They'll go to courses. I teach on these courses, 1 day, 2 day courses, and they'll walk away and they kind of feel like, have they really learned anything? They don't have access to a lot of the stuff they had before. And then you go to YouTube, you go to textbooks, you go to MDTs, multidisciplinary meetings, for those that don't know, read publications, talk to colleagues, go to more radiology courses, even looking at AI. I've seen people trying to upload things onto AI to try and get things to explain it to them. And it works, of course it works. But I think now what we've done together is really create something quite amazing where you've got a kind of ongoing access to a lot of material. And genuinely, in the 2 days or the entire course that we do together, you learn a lot and you'll be able to do pretty much most of the radiology that you will need in your practice. So I'm going to give you, yeah, and that's just me doing going through hip MRIs. So at first, it feels like there's a whole load of knowledge, and you think this is impossible to put all of this into this little bit. But like most things in life, you don't need to know everything. You need to know the relevant things, the things that are going to be useful to you. And so I believe, and I think we've done it. We've created a course where we've siphoned down all that information to be the information that you will require if you've got a patient that's saying, "Listen, I've got something going on my knee. They've done a scan. Can you have a look? And can you explain what's going on?" So this picture of me and this picture of Irfan, and this is what we're meant to be doing. Kind of, we're trying to build this bridge between us, right? And this bridge doesn't always work. I'm writing stuff, you're reading stuff, you're asking stuff, I'm writing stuff, and sometimes it all gets lost in the communication. But this is what we're trying to do. We're trying to break that down. So this is the thing, especially after this, if you've got someone with a knee problem, right? A patella problem in specifically, then after this one webinar, I'm pretty sure you'd be miles ahead of anyone else that's in the game right now. So our learning objectives for the next 40 minutes, I guess, is identify imaging that you require, be able to interpret some key pathology on some specific imaging and interpret some reports. Yeah. So let's say you've got someone, they've come in, right? And you're thinking to yourself, oh, they've hurt their knee. What should I do? What's the best imaging, right? So X-rays, MRI, ultrasound, nuclear medicine, these are all things that we've heard of, but what are they for? So X-rays are very, very good at a first line way to look at something, right? First line X-ray, right? If it's completely normal, and you still got someone who's got pain, then you may want to move on to something else. And this is where you kind of diverge. It's MRI or ultrasound. Now, ultrasound is very, very user dependent, right? It depends on the person who's using it. I mean, an ultrasound probe in my hands will hopefully be better than an ultrasound probe in a young registrar who's just started MSK imaging. So it's going to be operator dependent. You need to find someone who's good, or maybe get good at it yourself. And there's a few courses out there. And also, the ultrasound can only go so far. So it only goes sort of, we do the superficial structures, some of the ligaments, some of the muscles, some of the tendons. It won't go into deep structures like menisci, ACL, PCL, and all that kind of thing. It just can't do that, right? X-rays can't do that kind of deeper structures. You're only looking at bones. So that's when you need to go towards an MRI scan. Right. Nuclear medicine is not something we're really going to go into today, but that is something that we may bring up in the course later on, but not in this. I think it's just going to be too difficult for us right now. So, right, hopefully everyone knows what we're looking at. I'll give you a couple of seconds just in case you're not sure. All right, it's not an elbow, it's a knee. So what I'm going to do today is just demonstrate how we would go through things on the course. So first off, what we do is build a base knowledge of anatomy. So most people will get an X-ray at some point for their patients, and so this is going to be your femur, right? And then sometimes you're thinking, which one's lateral, which one's medial? For those that don't know, medial is on the inside of your leg, lateral is on the outside of your leg, right? So yes, you can look at the fibula. Fibulas can probably be the best way to know which one's outside and which one's inside. And if you're ever unsure, just think that like to be like an L, that's going to be lateral or the outside, okay? And this is going to be the medial aspect. You've got your tibial spines that's sitting here, and then you've got your patella that's sitting, and that's often ignored on this particular view. But that is your patella that's sitting there. Don't think it's some weird looking lesion. These are going to be your muscles coming down, and this is underneath here is going to be fat. Everyone's got fat underneath their skin, unless you're some sort of next level 5% fat bodybuilder kind of person. But generally speaking, there's going to be a bit of muscle, a bit of fat, and then there's going to be the skin there. If you're ever unsure, try and reset your eyes on based on what you're seeing. So if you see something that's very, very black, okay, you think to yourself, what is black in this particular image? So air is going to be black, or if it's somewhere between air and this, then you think it could be fat. This is what soft tissue looks like, and that's what bone looks like. So just try and reset your eyes if you're ever worried about a particular lesion, or work your way backwards. So this is your AP view. And this is your horizontal beam view. This is from the side. Very, very useful because you can do a few things here. So first off, you've got your tibia, you've got your fibula, you've got your femur, and then you've got your patella. So now you can see your patella, or this patella, a lot better, right? A lot better now. Now, the other thing you can do is have a look at this measurement that's over here. And you can see this is the patella tendon, and your quadriceps tendon's over here. So try and identify where this patella is. If it's all the way up here, then this is probably torn. And if it's kind of flapping around down here, then something over here is torn, because there's like a balance, like a constant tension between this and this, the quadriceps and the patella tendon, to keep this patella in place. Believe it or not, the patella doesn't want to hang out. It doesn't want to stick around. It wants to move outwards most of the time, or upwards and away. But these tendons and all the ligaments that keep it there are all the things that will keep it in place. Now, there's predisposing factors for someone to have a problem with their patella. One of them is that they could have a really long patella tendon. So what you do is get the patella tendon length, and you get your patella length, and you get a ratio of the two, and that will tell you whether it's too high or too low. Too high is called patella alta. So I always think of like going to pray at the altar. So be very high. You talk to some higher being. So patella alta, and patella baja is below. So B is for below. And that's going to be where the patella is a bit low, right? So it's just a silly way to remember things. If that pops up in a report, at least you know is it high or low, right? So that's one way to do it on an X-ray. That's a patella. Now, in these X-rays, you also want to look at this area over here. This can be the suprapatellar regions. Sometimes you may have a bit of a horizontal line here. That's not good. If someone's got a horizontal line, then you're probably looking at some sort of fracture. You've got blood, you've got fat, and that because they don't mix, they kind of sit on top of each other, and you end up getting a horizontal line. So if you ever see that, you probably should be a bit worried. I probably would say that is a red flag. Okay, so this is one of the concepts I'm going to introduce to you guys, right? Think about this in a 3D point of view, right? So when we're looking at 2D images, it can be a little bit difficult to try and think to yourself, okay, how does this work? How does this relate to things around you? So I want you to believe or think about the patella being this baseball, and the trochlear groove where it sits is going to be the baseball mitt. And what you'll often find is that the one side of the mitt is slightly larger than the other side, and that's trying to keep the baseball in place, right? Because the last thing you want to do is drop the ball and lose the catch. So similar with the knee, actually. The knee has got one side that's holding the patella in place a bit like longer, and one side is a bit shorter. And actually, you know what? I'm going to go through one of the cases right now. So let's have a look. So these are the things that you get when you access the course. You'll be able to get this course, this case too. If you guys want, actually, I'm going to give this to you guys free. What we'll do is I'm going to just send this in the chat, and then if it doesn't go to everyone, then maybe one of my colleagues can send it to you guys. So chat, where's the chat? Can't find the chat right now. Oh, there it is. Okay, it's on the side now. So I'm going to put that there. So you'll be able to access too. And so what this is I painstakingly made the entire anatomy of the knee, right? And it's labeled for you guys. So if you're ever in a situation where you've got a patient and someone's, oh, something's wrong with the popliteus, then maybe you can go to this and have a look. Oh yeah, Imran's labeled the popliteus for me, and you can follow it, can't you? So you can see the popliteus was labeled there. You follow that, follow that, follow that, and you can see it goes all the way to the lateral aspect of the knee. And you can go through it all the way like this, all the way. I've labeled absolutely everything that I could that I thought was appropriate for us to be able to go. So let's go from the top. This is going to be the quadriceps tendon that goes all the way down. And then you can see the patella. Can you see that? Oops. Let's go all the way down like here. This is the patella, right? Come a bit further down, and that's going to be the trochlear groove. So I've labeled it. So you've got the patella apex, you've got your lateral patella, and you've got your medial patella. Can you see how this is slightly longer than the medial? Because the patella wants to leave and wants to go away from you, not into you, wants to go away from you. And that's why that lateral aspect is slightly longer and the lateral patellar facet is slightly longer, just to try and keep it in place. There are other factors, there are other things that keep it in place. You've got your medial patellofemoral ligament, you've got your lateral patellofemoral ligament, you've got your quadriceps, and your patella tendons are also keeping it all in place. Keep coming further down. There's various other bits of anatomy that we'll see here as you come further down. Oh, sorry, why is that there? Okay, let's go back. This way, that's the quadriceps tendon. And then actually, we forgot the patella tendon. The patella tendon is this one down here, all the way down here, right? Down here. So that attaches to the tibial tuberosity or the tibia. Now, the other measurement that is very useful to identify whether someone's got a predisposing problem with the patella is to identify the TTTG. It's basically just a measurement to show how far and away the tibial tuberosity is from the patella, the trochlear groove. So what you do in radiology, you put your mouse here, you come all the way up, all the way up, all the way up until you see the trochlear groove. And then you draw a line between here and here, right? Between here and here, and that's your distance. And if that distance is very big, then you could be worried about this person having a slightly wobbly patella, and that may predispose it to moving. Now, remember about the mitt I was telling you about. So normally when you try and catch a ball, you catch it like this. But if you had a flat hand, you're probably not going to catch it, are you? It's going to just wave all over the place. Now, this is the problem now, right? I've gone and searched, turned something on the camera, so it's going to move my head. Okay, anyway, so what we can see is sometimes people will have a very, very flat trochlear groove. So you can see the trochlear groove looking like this, but it can be very, very flat like this. And if that happens, then they're going to be more predisposed to basically dropping the ball, right? That could happen. Okay, good. So what we'll do is we'll go to the, oh yeah, so the next thing, when we come back to this, I'm going to show you cartilage. Now, cartilage is a really big deal, right? Especially as we get older, cartilage can disappear. So what we'll do is have a look and try and show you what cartilage looks like. So cartilage on an MRI scan. So you've got bone, that's the very, very black stuff. Then above that, you've got this kind of intermediate signal stuff, right? So that's between here and here. And you can see that now all the way around like so, like a layer, just these two layers are like this. And that's your cartilage. Now you may have spotted there's something abnormal going on here. That doesn't look quite right. Right, so what is going on there? This is not actually a normal scan. What you can see here is you've got your chondral surface here, and then it looks like a linear line going down this way, and then another line going like this way, and that must be therefore a chondral fissure. Chondral fissure with a bit of a focus of bone marrow edema. How do I know there's bone marrow edema? I mean, what kind of scan is it? First off, it's an MRI scan. You can see that the fluid is very, very bright. So therefore, anything in this particular image that's bright where it shouldn't be is going to be fluid signal. This stuff must be fat, subcutaneous fat. So it looks like it's a bit darkened. So whatever we've done, we've got bright fluid but darkened fat. So therefore, what we've done is dampen down the fat signal so we can have a look and see what true edema is. If fat was bright right now, you probably wouldn't see that so well, but there's definitely something going on there within the patella. So a bit of chondral abnormality located there. Now, when we are looking at chondral surface, we actually grade it, right? And we actually look at the patella, the chondral surface, and give it kind of grades, like how bad is it or how good is it? So this looks like a nice chondral surface, doesn't it? Very, very thick, no fissures, no abnormalities. When you get a bit of thinning like this, maybe 50% of it lost, that's when you want to be looking, that's when you'd be saying like this can be like a grade 3. It goes grade 3 and then all the way to grade 4, where there's a full thickness fissure, full on edema located here as well. So that'd be full thickness grade 4 chondromalacia. Okay, so that's your chondromalacia. Oh yeah, and then you're going to go here, and then there's like you've got to think about this as being layers, right? So because somehow what's happened is that this is kind of pulled away like so. And oh, hang on, someone's asked a question. I'm going to come back to that. Let me put that here. So when you look at this and it goes across like this, you can see like a flap coming up like this. So someone has asked, and it's a good question actually, does this grading apply when looking at skyline view of ultrasound? No. And the reason is, so I want you to try and remember this, right? That's the chondral surface. Let's see what the next slide is. Otherwise, I'm going to go back to my scans. So back to my scan, and what I'll do is just show you. So I've labeled every single view for you. So there should be a coronal view turning up. So, okay, so let's go full screen. Again, can you see the chondral surface here? Like I showed you the patella, you can see chondral surface here as well, right? So if we went back to the X-ray, oh, you said ultrasound. Oh, sorry. Okay, an X-ray you won't be able to see it, and ultrasound is difficult. I wouldn't. I personally wouldn't be calling chondral fissures or anything like that on an ultrasound scan. X-ray, you won't be able to see it at all. And if you go back to the, I thought you said X-ray at first. So X-rays would look like this. That you can't see any chondral surface there whatsoever. And X-rays, you have to remember, right? That ultrasound can only see superficial things. So you'd only be able to see. Let's go to here. And you said axial. Oh, you said skyline view, right? So let's go back to skyline view. The equivalent of skyline view on an MRI scan. That would be your skyline view on an MRI scan, I guess, right? So it can be really difficult to really interrogate all of that because when you try and put the ultrasound probe there, you can't go through the bone and you can't really angle all the way along like this. It's going to be very, very hard. And you can't angle towards the actual femur and see what the chondral surfaces look like there. So I probably wouldn't really go anywhere near saying anything about chondral surface on an ultrasound scan. The best way forward is not going to be ultrasound. It's going to be an MRI scan if you're worried about chondral abnormalities. Now, X-rays can be good to look for the secondary findings like edema and all that kind of thing. Okay, good. So this is chondromalacia. It's lots of words. Don't worry. I'm just trying to illustrate that there are different levels to this particular thing. Right. So this is the key. This is the key. So obviously there may be some spelling errors because of my dyslexia, but what we'll do, we'll have a quick read through this particular scan that you will have. You've got a patient, they've had knee pain, and you've got this report. So indication, long-standing knee pain. Okay. To be honest, I'd rather have more detail than that, but I get it. Sometimes you're in a rush. There's a very large osteochondral defect involving the posterior third of the lateral femoral condyle. I don't know what that is, measures up to 5 centimeters in AP diameter. No lateral meniscal tear has been identified. No lateral compartment chondral defects have been identified, so no chondral problems. LCR, the rest of the posterior lateral corner structures. Large screen again. Oh, yeah. Okay, fine. Sorry. Let's do that. Let's read this. Okay. I'm going to read it out. So, no medial meniscal tear. That's good. Has to be a dent. Yeah, okay. No medial compartment chondral defects. MCL, pes and tendons are okay. ACL, PCL are fine. Someone's made a spelling mistake. Patella is lateral from the trochlear groove. TTTG measures up to 1 centimeters. Edema in the supralateral aspect of Hoffa's fat pad in keeping with impingement. Quadriceps and the patella tendons are normal. So you may have a report like that with spelling errors, like I've just shown you, and you'd be thinking, all right, I have no idea what I'm going to do. Patient comes in and says, all right, can you help me? Because I've got the scan, sticks in the CD, and you're thinking, all right, I don't know what I'm going to do. Let's have a look. Let's have a look at this scan. So what did they say first? So they said there was no medial or lateral meniscal tear. So we are going to let's go from this side. I'll actually, on the actual course, I'll go through this properly, show you exactly how to do it. Let's go on this side. We're going to concentrate on this side and have a look. So they said there was no meniscal tear. Good. So we don't have to worry about that. This is the chondral surface. We don't have to worry about that. They said the ACL and the PCL are intact, so we don't have to worry about that. They said there's an osteochondral defect somewhere on this one. So where could that be? It said lateral femoral condyle. Okay, so right, I need to figure out which one's lateral and which one's medial. So we said the fibula is going to be the most outside thing. Yeah, there you go. So that's the fibula. So that must be lateral. And they said lateral femoral condyle. So that's the femur. There may be something there actually. They did say it was a lateral femoral condyle osteochondral defect. Okay, fine. So what we'll do is go see the other view. We'll try and see this view. So let's scroll through. And there it is. Can you see? We were talking about chondral surface there, and you've got this massive defect there, and then you've got your chondral surface there as well. So this looks like a really big osteochondral defect, and I wonder whether the osteochondral defect could be sitting over there. Now, the other thing they did mention was something called Hoffa's fat pad impingement. So Hoffa's fat pad is this stuff over here. Hang on, this one over here. And so when you get Hoffa's fat pad impingement, it's where you get basically what sounds like impingement of the fat pad. So for whatever reason, the patella's kind of squeezing the fat, and that fat is getting a bit edematous and a bit angry. So the best way to see it is going to be on this view where you're looking from the side of the leg, and you can see that. Can you see? This is what normal fat looks like, normal fat. And this is kind of a bit brighter, and this is what fluid looks like. So somewhere between the two, isn't it? There's a bit of fluid, and then this is fat, and that's fluid. So there's a bit of edema sitting there. So therefore, that means that there's been a bit of pinching located there. They also said the TTTG was also slightly increased, and the patella was laterally from the trochlear groove. So let's have a look at this. That's a chunk of osteochondral defect, by the way, in case anyone's interested, which wasn't mentioned in the report. Coming up. And then let's follow this down. So let's go for the tibial tuberosity, which is all the way down here. That's the patella tendon. You're coming up. Keep track where we were. And then look, this is going to be the distance. And actually, when you look at that base form, it looks a bit flat, doesn't it? So we've got a bit of a flattened trochlear groove. and it's all kind of going towards the side, isn't it? So this is not a stable knee at all. And then now again, you can see that edema that's sitting within the superlateral aspect over here. Again, just to reiterate something we talked about earlier, this is the patella length. That's the tendon length. You can do the Insal-Savati ratio and figure out whether patella alta or patella larga. That's going to be another way to see what it is. Generally speaking, they do say it's an X-ray finding, but I use it for MRIs as well. And especially if it's particularly obvious, I will mention it. Okay, so this is one way. So if you had the patient, you read it, osteochondral defect, lateral femoral condyle, Hoffa's fat pad impingement. So now, hopefully, especially after going through our course, you'll be able to talk to your patient, show them views. These are going to be the three views that all you need to explain it, and go through it with them. Explain it really nicely, and then look amazing. And this is the thing, like we've broken this down, right? A lot of the time you'll have loads of sequences. Don't worry about those sequences. These are the three views and the sequences that you need to be able to get through most of what you need to do when you are with a patient in real life. Okay, good. So now you've got someone. Let's go full screen again. Full screen. Okay, so now you've got someone. They've come in and they've got knee pain, and you've got this knee MRI, and they've said there's something there, right? This is where we've got to. These are the red flags we talk about. These are things we need to worry about. I'm going to take a quick sip of my tea while you guys have a look. Okay, so I know it's good pointing, red herring, don't worry about that. That's not the problem. There's this thing over here. This is abnormal. This is the kind of person that come in, they'll say, oh, you know what? I just kind of had this locking feeling and a fullness in my knee. And what you've got here, this is fluid. That's your fat. That's fat. This is kind of something in between. It doesn't look quite right. And there's a bit of edema located over here as well. So this needs to be investigated further. This needs to go to someone else, right? Ideally, a sarcoma center. They'll do another kind of MRI scan called a gradient echo, because this would be something called PVNS, long name for badness. Okay. But it's not like badness as to point that, they're going to lose a leg, but they probably do need to do something about it. And there are very severe forms of this, right? But now, what about the kind of problems where you've got someone that could potentially lose a leg, right? These are things you need to be concerned about, the real red flags, right? So I showed you the X-ray from earlier. Now we're looking at this X-ray, and at first it may look okay. It doesn't look like much going on, especially when you're looking at the femur. The femur looks okay, but that tibia doesn't look great, does it? Because now when you look at it, it kind of sticks out a bit and comes back in, sticks out. And this part's okay. This looks very thin. This looks very thin. If you look at the bones, can you see these kind of lines going right down? These are trabecular pattern. There's not much in the way of trabecular pattern here. It's all kind of gone. It almost looks like someone's got a thumb with a bit of chalk and just smudged there and left the rest alone. When it's smudged like that and you can't really define contours, you have to be worried. And what we call an ill-defined lesion. Ill because it's ill-defined. You can't get a pencil and draw all the way around it. That's not a good sign. Now, when you look at the cortex, this is the cortex, the surface of the bone. That looks very nice. This one looks a bit hazy, again, like someone smudged it a bit. So there's a bit of cortical breaching here. It doesn't look right. It looks very, very abnormal. And also, when you now look at it, this is what normal subcutaneous tissues look like. This one looks a bit streaky. So there's a bit of soft tissue swelling around here as well. So this is not good. This is a bad situation. You've got someone who's got knee pain, you've got an X-ray, they've got an ill-defined lesion located within the proximal tibia, and they're a young patient. These are what growth plates look like in your young'uns. So they're a young patient. So this could be lots of things. Osteomyelitis, it could be Ewing sarcoma, it could be an osteosarcoma, loads of things. But this needs to be sent off. This needs to be sent to someone as soon as possible to try and get this dealt with as quickly as possible. Now, on the other hand, let's look at this person. Again, a young patient, right? We know they're young because they've got growth plates. Growth plates look quite nice, but then you've got this sort of nubbin of this bone that's just sort of sticking out. You think, what on earth is that? But unlike the last one, you can see trabecular pattern. You can see the cortex quite nicely. This is a non-aggressive lesion versus the aggressive lesion that we were talking about earlier. This is going to be an exostosis. And then you can do an MRI scan to make sure there's nothing else going on. And there you go. It's an exostosis. Can be very, very common. Not usually a problem unless you hit these certain factors, which I'm not going to go into right now. Right, so I am going to hand over to my good colleague, Dr. Ahmed, who will now talk about some of the aspects of management and the things that are appropriate to you guys who are actually looking after the patients. So I'm going to just hand over to him. Irfan, are you around?
Yeah, do you want to do the dislocation case?
Oh, yes. Oh, yeah, let me do the dislocation case. Sorry, yeah, good point. So let's go to case number A. I forgot about that one. And let's go full screen. Okay, so what we're going to do, I am going to go through this case, but I'm going to let you guys look at it first. And what I mean by that is just scroll through. Hang on. Is someone else on? Okay, let's scroll through. So I'm scrolling through. So by the way,
No,
don't get
you have
worried.
to
This
share
is
your screen.
Oh, I haven't shared the screen. Sorry. Let's share screen, desktop to share. Thank you. Okay, so everyone can see my screen now. Sorry about that. I forgot about this case. Let's go from the very side. So this is an MRI scan, and what we'll do is go through this together. So I'm going to do one scroll through for everyone like this. And then I'm not going to say anything first, and then we'll work through this case. And this is exactly what we'll do on the actual full day. We'll go through some real life cases of real life people and their pathologies. Let's have a look. Okay, I'm going to keep scrolling through, keep scrolling through, keep scrolling through, keep scrolling through. Okay, good. So, right, let's get my, because I messed around my thing, I'm going to get the chat back up and the Q&A. Okay, so if any questions come up, then please do throw in what you think. If no worries, if you don't know just yet. So what we'll do, we'll work through this together from the very beginning. So this is an MRI scan of the knee, and we're looking at the sagittal views on the first instance. And what we know is that fat is dark and fluid is bright. So we're looking at we can't see fibula. This must be medial. Scroll, scroll, scroll. PCL, ACL. Coming. And then look, this looks very bright, doesn't it? Looks really bright. Looks very bright compared to the rest of the bone. Something's up. Something's up here. Something's happening with the fibula, so lateral side of the knee. There's something up. All right. Let's have a look. So this is the patellar tendon. We're coming up. And actually, look at that medial aspect there. That's a bit bright, isn't it? It's almost the same brightness of that one. Something's happened here. Okay, let's have a look at the rest of the scan. Scroll through. Oops, wrong way. We're going to look at this side. And again, you can see all that brightness. That's not good on the lateral aspect of the knee. And then that patella, where is it? Yeah, it looks very bright around here. And maybe, yeah, very bright around here. Definitely looks really bright around here. Okay, so what's happened? What's going on? Well, what's happened is the patella's escaped. It did escape at one point, and this does look a bit flattened, so they're probably slightly predisposed to it. And the patella has gone from this side all the way around to this side, hit this lateral aspect, the outside of the knee, and then come back in again. And so that has resulted in a bone bruising there and a bone bruising there. And this is a very typical pattern of a bone contusion, a lateral patellar dislocation bone contusion. Now, if something like that happens, you've got to be worried now. One, the stabilizing thing could be the medial patellofemoral ligament. That doesn't look normal. I mean, that could get injured in these situations and get torn. This one looks like it hasn't torn. It can still see it there, but the most medial aspect of it does look like it's got a bit of a sprain. So what you see, whenever you've got any sort of edema on the medial aspect, the inner aspect of the patella and the outside of the knee, you're probably looking at a recent patellar dislocation, and they're predisposing factors that Irfan will hopefully go through. Good. I hope that was useful. I've shown you a hopefully nice case of a lateral patellar dislocation. I'll hand it over to Irfan, and at the end, I'm just going to quick do a rundown, and I'll hopefully give you a really good offer for the MSK Playbook if you're interested at all. So I'm going to hand over to Dr. Irfan now.
Hi, Imran, and welcome everyone. My name is Dr. Ahmed, and I'm the attending physician for the MSK Playbook course. Welcome. Thanks for all your shares and likes. For those of you not familiar, we've got a website. So if you do want to check out some of the materials, do go onto the MSK Playbook website, and you can access loads of free materials. So today I'm going to be talking about, after that introduction, everything to do with patellar dislocations. So we'll get straight into it. Okay, just sharing the screen. All right, so look, this is a very common example where a patient's been brought into the sports medicine or MSK clinic, and essentially we're here to make your life easier, to turn that bookshelf of dusty books into that really focused MSK history that you're going to apply in clinic. And here are the key questions or cheat codes to take away. Those of you that have been on the MSK Playbook course will be familiar with our infographics where we break down the key imaging findings. So if you ever get stuck or if you ever forget, you can always go back and reference these and you'll have lifetime access to it. So how do I work up the patella in the clinic? Now, most people on this webinar will probably resonate with this as example. Somebody's come in, they've had a patellar dislocation, they've handed you over a CD. I don't know why it's a CD because I haven't worked anywhere that's got a CD drive for the last 5 years. But often they're going to ask you, look, show me the key views or explain the scan to me. And the second question is, look, am I at risk of a secondary dislocation? And if so, what can I do about it? So a key part of this is going to be able to break down that theory, and we've put in 5 key factors for you to work up as part of your clinical assessment. And you're going to understand really how to integrate that into your assessment. So we've got 5 criteria from the imaging, which is your height. So we've talked about patella alta and baya. Are there any dysplasia features? What's the TTT distance? And is there any evidence of patella tilt? And essentially, these are all imaging findings. You're going to use that as part of your clinical workup alongside the clinical findings, injury history, and the functional demands of the patient. And this is going to give you a really good idea about the stability of the patient. And that will help you decide what the next steps are. And the thing that we really love is those cartilage, bone lesions, and soft tissue injuries, and how we're going to best rehabilitate the patient. So bringing this all together is a bit like putting together a piece of a puzzle. You're bringing together individual imaging criteria alongside the clinical assessment. And you're thinking about with this patient, are we going to go down a rehab or non-operative route, or is there things that we need to fix as part of an operative management protocol? So think about those key findings, think about those MSK Playbook imaging criteria, and think about those risk factors for re-injury and associated soft tissue or ligamentous injuries. So you're going to put that CD in, and you're going to have a look at the images. So what do we know about the studies? Well, there was a Cochrane review in 2023 that looked at patella dislocations, so primary patella dislocations. We know there's a high risk of secondary redislocation. People quote about 40%. What do we know about operative versus non-operative management? Based on the studies analysed, there's overall a low certainty of evidence, which kind of puts you in this middle ground. So there was no difference whether you went through operative or non-operative management in terms of risk of future dislocation, pain scores, or functional scores. But often you've got a patient in front of you who's asking you, look, I've had this one patella dislocation. Am I at risk of a second one? We've got some really cool studies where we've looked at patients that have had first or primary dislocations and looked at the risk factors. This systematic review and meta-analysis looked at 17 studies. The caveat is an observational study and looked at the known risk factors for dislocation. So on the left-hand side of the screen, you'll see all the normal contenders, having a younger age, being a stage where you've got open physis or developmental stage, trochlear dysplasia that we've discussed earlier, elevated TTT distance or the patella wanting to escape or move laterally, and having a high riding patella or an outer position. Really interesting in this series that gender didn't actually affect whether you were at risk of secondary dislocation, and contralateral dislocation didn't make a difference to secondary risk of dislocation. I would put one word of caveat there. We do have a subset of patients that are perhaps maybe hypermobile. They've got increased laxity of their ligamentous structures. And definitely that's the type of patient, if they've had multiple dislocations, you're probably going to want to do a Baton score and assess the structural integrity of the knee. So we've got loads of imaging findings, we've got loads of information in the report, and this is the time we start doing some calculations. Now, it's not such a big number where you have to get your calculator out, but I start to tot up some of these risk factors. So we've got a patient, I'll have a look at the report, and I'll start to see how many imaging findings are there that are suggestive that this patient may be unstable. The good thing about this study, it says, look, if you've only got no risk factors, then there's about a 10% chance of redislocation. But you can see as you go up to 3 or more risk factors, that risk of secondary dislocation goes up to 70 to 80%. So quite a significant jump. And being able to take those key bits of the imaging report, hopefully getting to a stage where you can show your patient in clinic, is actually really key. And we've got these key infographics that you can use and reference as part of your clinic workup. So the second question they'll often ask you in clinic is, look, I've had a patient with a knee dislocation, to MRI or not to MRI. This is an interesting series of 324 patients with lateral patella dislocation. So the patella has gone all the way out laterally, it's no longer supported and has come back in. Of the 195 patients in this study that had such a significant injury that had that very typical bone bruising pattern, lateral femoral condyle and medial patella facet, they found that there was quite a significant burden of secondary injuries, and it's really important that we look and identify these on MRI. Just about half of the patients had a tear of the MPFL at the patellar insertion. About a quarter had a tear of the MPFL at the femoral attachment, and 13% of patients had a tear at both sites. Interestingly, in the study, they found that female patients were more likely to have a meniscal tear, and 13% of patients had this loose body that was floating around inside the knee. So I think you do get a reasonable amount of pickup. And if you have that primary dislocation with a significant traumatic injury, doing an MRI and thinking about those key risk factors is really important. So look, we've got to a stage where we can look at the MRI scan, and hopefully on the left of the screen, we're going to take that really detailed report, break it down and correlate it with the clinical findings, and hopefully get to a stage where you can explain the patient the scan and bring in those key views as part of your management plan. So on the right of the screen, we've got the axial sequence, and this is that key bruising pattern we're going to look for. You can see there's bruising of the lateral femoral condyle, medial patellar facet, and you're going to explain to the patient, look, there's lots of things on this report, but actually you've got a very typical pattern of soft tissue and bone bruising that we see with a dislocation. We're going to look to see what we can do to optimize your rehab, work on some early rehab, and you've got really good potential for this to get better with rehab because the rest of the structural findings on the knee scan look actually okay. So you've got good potential for this to get better. And you've taken away that sort of anxiety about the report. You've shown them a couple of key images and you're able to explain what's going on very effectively. Now, we know rehab is important, and it's not just after dislocations. This is an interesting MRI study where they looked at patients after ACL reconstruction, and there's a US study, so they put everyone in an MRI scanner, reconstructed the ACL, and looked at their PFJ over a 5-year period. What they found interesting was those patients that had reduced joint forces through the PFJ on Holt testing actually had a higher risk of developing PFJ-related changes and post-traumatic osteoarthritis 5 years down the line. And we know how important rehab is, and thinking about the integrity of the patellofemoral joint and how we can optimize joint loading and joint reaction forces. So it gives you loads of really cool information that you can use as part of your workup, and it's really useful. Now, I've given you some of the key studies. We've gone through a lot of information, and what's really cool on the course is you'll have access to these label diagrams and images. So perhaps you want to go away and consolidate patellar tilt. We've got some label diagrams where you'll be able to go away and have a look at how to work out the angles so you can consolidate and use that knowledge in clinic. So we're really excited to have you all support us. Thank you for the likes and shares. This is a little bit of a sneak preview to an upcoming blog that we've got going. Earlier on, we spoke about bone marrow edema, chondromalacia patella, and cartilage lesions. During the MSK Playbook course, we'll introduce you to a number of clinical decision aids and aid memoirs, or your cheat codes for clinic. And this is one for chondromalacia patella, and it will help you understand how to work up the patient in clinic. Is this more of a trauma or overuse type picture? Is this a patient that's got hypermobility type syndrome or tendencies or chronic pain features? And perhaps maybe there might even be degenerative changes, or they might be in a slightly older adult category. I find that these clinical decision tools are really useful, and we've found them really useful for our trainees to help them understand how to work up the patient in clinic. So in clinic, we'll assess their alignment and loading. We'll look to optimize their joint mechanics, think about appropriate exercise therapy, education, and excitingly, regenerative approaches. So if you're thinking about injection therapy, PRP, or other treatments, then watch out for this upcoming blog. So if you want to know more about MSK imaging and particular MRI of the knee, come and join us for day 2 of the MSK Playbook live course, where we have got MSK evidence updates on ACL injuries, meniscus, and chondromalacia alongside the red flags module. Now, we developed this because a lot of our clinicians that are reading reports often find difficulty with what to do next with a red flag lesion or how to work up patients. So we really look forward to inviting you to that module, and I will hand over back to Imran, who's going to take us through to the course offering.
So hi everyone, I'm back. So what we're going to do is I'm just going to take, okay, so obviously we're going to answer any questions if they come up. So please do ask your questions. I do want to try and make this as useful for you guys as possible. So as Ifran said, we do run it's a 2-day course essentially. We just couldn't fit everything in to be able to be a 1-day course, but with recordings and stuff, you can kind of dip in and out as you need. This is going to be our 4th reiteration of this course, and we've taken on feedback as we've gone forwards to make it better and better. You can go to our website, find more details as to exactly what it entails, and think about whether this is something that you would want to do. Genuinely, I've been on a lot of courses, and Irfan's been on a lot of courses, and there's not a course that kind of does both. There's always like more to one there are than the other. You may go to a radiology course, but it's so radiology, you're like, oh, they're just talking about all this stuff I don't understand. And then you may go to one which has kind of not very much radiology and not very much to do with imaging. So this course really is quite unique. We've built it together and made what I think is phenomenal, and we've had some really good feedback from a lot of people. If you are interested in signing up, this is going to be the link that you could use. You can use your phone, scan that code, or just go to the website and just go find it and have a look. The offer we're going to put to oh yeah, I'll share the page in just a second. Okay, so the page is going to be, I'm going to do it right now. So if you go to mskplaybook.com, type it on Google or turn up and type in MSK20, MSK20 for a 20% discount. That will be live for the MSK discount will be live for the next 48 hours. So after 48 hours, we won't be doing a 20% discount. We don't want to, yeah, I mean, I think this is going to be the best way to make sure we don't get completely overwhelmed. We're going to be doing it sometime next year. So please do have a look at the website. Do link that. And if you do have any questions, obviously you can ask them now. But otherwise, if you do have any other questions that come up later about institutional access in particular, then email at info@radiologyseminars.co.uk. Oftentimes there'll be 20 people saying they want to turn up. Can we do an institutional discount? Or you work in a big area where people got lots of physios and those kind of people who want to come to this course. Yeah, we can talk about that and try and get the best deal for you. So do have a look, do check it out. At the very, very least, next time you have someone with a patella injury, you'll be able to go through the images, go through the scans, explain to them, talk about risks that they may have. And if you do want to take that learning a little bit further, be able to explain most things, if not all things, to your patients, then do please consider signing up to our course. So, with that, I think we don't have many or any other questions from what I can see. So I guess it's a thank you from me and Irfan and the rest of the team at MSK Playbook and Radiology Seminars. Oh, there was one Q&A thing. Does lifetime access include teaching or recording slides only? So it gives you access to access is to all the slides and all the scans and the labeled images that I showed you earlier. But I've done labels of the shoulder, the knee, the pelvis. I've done it all. I've done them all. Yeah, the wrist, they're all there. So you get lifetime access to all of that. And what we do is, as time goes on and there's new research that comes up, the slides get updated and there'll be things that'll be added. Sometimes people ask me, "Oh, can you add another diagram of this?" And I'll add that. So if you are a previous attender, you'll have access to any future iterations of all the material that we have. With regards to the recording, you get about 30 days access to the recording afterwards. And yeah, I mean, yeah, it's up to you. If you think it's particularly useful, and as the years go on, we keep updating it, you can come again. And if you've been a previous attendee, we can talk about maybe giving you a discount as well. Okay, good. I think we've answered all the questions from what I can see. So again, big thank you for giving us your evening, and I will see you next time. All right. Yeah. Okay. Bye.